Good morning. Welcome to a wonderful presentation that you're going to receive today from our very special sponsor, Black Health Matters, and Boston Scientific. It's a wonderful collaboration that they brought to NPHC and to our members. The information that you're going to receive today is about your heart health, your family's heart health, the community's heart health, and how we can do things a lot better to prevent things that happen to our parents or our loved ones or yourself. So please sit back, relax, and enjoy the program. Thank you. Now I would like to introduce Colin, who's going to take you further into the program.
Yes, good morning, good morning. My name is Colin Rock. I'm with Black Health Matters, involved with their partnership development. And we want to say thank you very much for joining us today. It's an important topic, as Donna has indicated, and as our panelists will indicate as well. I personally have suffered from vascular problems. I traveled, I had a knee operation, a clot worked its way up to my heart and my lungs. And so this is a very, very important and dear subject to me, as it should be for all of you. I have relatives who have lost limbs as a result of diabetes and heart disease. So this is very, very dear to me. And it's an important subject that you must share with your communities. And so we want to be able to establish that Boston Scientific, the Close the Gap program, and Black Health Matters have come together to share this information with you. Black Health Matters was started 11 years ago by our president and founder, Rosalind Young Daniels, who saw an opportunity to create a platform for education and advocacy around the inception of the Affordable Care Act. She knew that more of us would be getting insurance, more of us would be concerned with our health, and we needed a resource that we could go to through our website, through our social media, and our events like this to help share information in our community. So we want you to make sure you go to www.blackhealthmatters.com and you'll see a newsletter pop up. Sign up for the newsletter so you get weekly information from us, okay? And check our website out for a variety of different health issues and topics. It's now my pleasure to pass it along to a Boston Scientific executive by the name of Whitney Craig. And Whitney is the Senior Director of Federal Government Affairs for Boston Scientific. And I guess she'll tell you that she's an AKA as well. But it's all important, no matter who you or what organization you're with, this is still an important topic. So you want to pass it along to Whitney Craig. Thank you very much.
As he said, I'm Whitney Craig, Senior Director of Federal Government Affairs for Boston Scientific, and I'm very, very happy to moderate this conversation with you today. For over 20 years, Close the Gap, a Boston Scientific initiative, has collaborated with healthcare providers and stakeholders to improve diverse patient outcomes and treatment gaps. It is no secret that health disparities persist, especially when it pertains to heart health and treatments, and especially in the Black community. This panel has been convened to raise your awareness, provide education and action steps for your chapters and colleagues, and to empower you with tools to advocate for your own heart health and vascular health and the health of your families. We will pause now for a quick video to level set the conversation.
We know how to treat the colds and the coughs. We know how to treat the bumps and the bruises, the cuts and fractures. But how do we treat, I can't afford a day off work to see a doctor? How do we treat? I've never had a doctor who speaks my language. How do we treat? I don't know how to connect with some of my patients. How do we treat? You're not listening. We can't treat what we cannot see. So we have to look closer and see what we're missing. People, patients, misdiagnosed, misunderstood, overlooked. These are the people left out of a system charged with helping them. And it's up to us to find them in our communities, in our relationships, in our data. We're meeting them where they are, discovering who they are. We're taking an honest look to understand their healthcare needs and delivering effective ways to reach them. We don't have all the answers, but together we can find the way to address the gaps in our healthcare system, to provide something better, to find more chances to save more lives. It won't be easy, but we can help make it right, because no one should be missed.
Okay, let's get started. We brought together a group of distinguished experts, each with their own unique insights and experiences in the field of cardiovascular health. I'm going to let them introduce themselves. We'll start with Dr. Tochi. Here you go.
Thank you. Good morning, everyone. Good morning. Good morning, everyone. Good morning. Wonderful. My name is Dr. Tochi. I'm a cardiologist at Rush University Medical Center. I'm a full professor of cardiology, and my focus in cardiovascular health is cardio-oncology, which is heart disease in cancer patients. As we all know, heart disease and cancer are the number 1 and number 2 causes of death in the United States, and actually much of the world, whether developed or underdeveloped world, or developing, I should say. And the premise of what I do is that patients that receive cancer treatments, whether it's chemotherapy, radiation therapy, targeted therapy, immunotherapy, CAR T-cell, stem cell transplants, all the different kinds of cancer therapies, their treatments, to some extent, one way or the other, tends to affect the heart, because the heart is not a very resilient organ. And so it's very easy for these treatments to affect the heart. And when they do, it can be immediate or it can be long-term as cancer survivors. And so managing these cardiovascular consequences is particularly important in order for us to continue to maintain the longevity that we're getting from the improvements in cancer therapies and treatments that we currently have. One of my focus in improving community health overall is mentorship. So I am a mentor to a number of many medical students, residents, fellows in both cardiovascular diseases and oncology, to try to get the younger generation, especially those of us that are from the underserved communities, to get to positions of healthcare providers and also get to positions of leadership in order to help bridge the gap in cardiovascular care problems that we're having within our communities. That is my focus, and that is my resolution and what I'm dedicated to doing. Thank you.
Paul Jones.
Dr. Paul Jones. I'm a interventional cardiovascular medicine specialist, which means that I specialize in managing and or treating disease states of the heart and arteries, major arteries and veins throughout the body in a non-surgical fashion, utilizing essentially, more often than not, balloons and stents. I have about 25 plus years of experience in that space. We've done it very, very aggressively, at a very, very high level. I also have spent the last 25 years of my career partnering with hospitals, community hospitals, as well as community healthcare systems in an administrative role as medical director of their cardiovascular service line, and partnering with them and helping them hold themselves and all of us accountable of providing high quality cardiovascular care to the communities in which we were privileged to serve, and try and bring university caliber care to those communities, because unfortunately, more often than not, those communities can't get into the pearly white gates of academic medicine for whatever reason. So I've been committed over the past 25 years to that particular charge. I stand here today to try and help you as non-clinical lay people, as I understand most of the audience is, to try and help you understand how you can be very, very active as a participant and leader in trying to minimize this huge, huge problem of the diversity gap, which appears to be getting worse, not better.
Thank you. And last but not least, Dr. Marlon Everett, who's also my cousin.
Hi, good morning, everyone. My name is Dr. Marlon Everett. I'm a practicing interventional cardiologist here and the chair of cardiology over at Advocate Trinity Hospital here in Chicago. My hospital is is located right on the south side of Chicago. And one of my main focus over the last 7 years is really ensuring that hospitals like that are in underserved areas get the same resources and give the same resources to those communities. I practiced in a affluent area for 10 years, and then I moved over into a less affluent area, and I saw a stark difference in that. And so my whole focus has always been to ensure that patients on the south side of Chicago get the same treatment that they would get in some of the suburbs or even downtown Chicago. So that's me.
Thank you. So let's jump right into the questions. Dr. Everett, I'll start with you. Countless studies have shown that Black and brown individuals may experience delayed or inaccurate diagnoses, leading to disparities in treatment outcomes. Speaking specifically to the disparities in cardiovascular care, how can individuals advocate for their heart and vascular health for both themselves and their families?
Yeah, I mean, that's a great question because it's clear that there's disparities and a lot of disparities exist. But, you know, in my opinion, I think as patients, awareness, those are the things that we really should know. I mean, so many things are now available to us. So much information is available to us nowadays, right? So you have internet, you have social media, and so many different things. So I think that the best way that we can really advocate for ourselves is to be aware that disease states do exist. And most importantly, don't be afraid to talk to your doctor. Don't be afraid to go to the doctor. One thing that we can, as a Pan Health, is we are pillars of the community, right? So we essentially can go out and make sure that other people, all of our, I guess you'd say our neighbors, our friends, our families, and other members of our organizations, that we continue to have health fairs. We continue to talk about health. One thing we don't do as Black folks is talk about our own health. We don't do it, you know, as other folks do. They'll talk about it at their Thanksgiving and Christmas dinner, but we don't talk about that. So once we start getting to that level where we make it okay to talk about our health, that's when I think we'll be able to get better, and those disparities will decrease.
I agree. Dr. Chochi, do you have anything to add to that?
I completely agree with Dr. Everett. I think talking about health is important. One way that I've advocated for patients to advocate for themselves, other than having more people, or more of the underserved Black and brown people in healthcare leadership positions, which then basically to some extent levels out the playing field for everybody else. One way that patients individually can make that difference is by bringing in their community. And when I say the community, I mean their family members. You know, I have patients in my clinic, elderly patients in my clinic who can't take care of themselves. But then they have their daughter or their son or their cousin or their, you know, niece or anybody in their family. Sometimes some of my patients have come to clinic with their pastor. So somebody that could help advocate for you. And the reason I say that's important is because last night when we were at the table, we were talking at dinner, and I was talking about how patients can be advocate for themselves, and one of the people at the table said to me, how about the people that are not educated enough or not aware enough to advocate for themselves? And I do find that when patients are in the hospital setting and they have family members that are advocating for them, healthcare workers tend to sit up better. Healthcare workers tend to listen to them better. So I think it's important, even if it's just one, it could be one person, it could be 5 people, but have at least one person that is there with you, that can advocate for you, that is educated enough, that can ask the important questions. That makes healthcare workers sit up and listen.
Dr. Jones, expanding on that, what would you tell a patient who's advocating for themselves with their physician, and how to choose a physician and how to best align their treatment with what their needs are?
Wow. Without being overly long-winded, that can get pretty involved. I think Marlon touched on it. Can you hear me now? Yes. Oh, I'm sorry. So, again, without getting long-winded on the topic, because one could almost do a dissertation in response to that question. But Dr. Everett, I think, touched on it quite nicely. Dr. Tochi as well touched on that. I think the true answer lies in empowering that patient. Empowering that patient, again, to have the education and knowledge as a layperson, and be knowledgeable of the disease state that they have. Own that disease. And I'm going to choose something very, very simple like hypertension. I got hypertension. That's my disease. I own it. So I'm going to take the necessary steps to understand it. Take advantage of all of these educational resources that's out there, particularly in light of the advent of social media and all this other kind of stuff. It is inexcusable not to know this day and age. Just as I tell physicians, it is inexcusable not to know what you're treating. Okay? So get that knowledge. And then once you walk into the healthcare delivery system to see that provider, that physician, be it your primary care doctor, the cardiologist, or the nurse practitioner, you have certain expectations of them. You want answers. And don't be reluctant to challenge them. Because unfortunately, the other side of this equation is the deficits in having access to not just a provider, but a qualified provider that's truly interested in me.
Yes, right. Yes, right.
You got a lot of docs and providers out there getting a check. They show up to work.
Right.
Healthcare is come on, man. This is a mission. Right? These people's lives we're dealing with. Okay? So not all providers are in this for, we take this Hippocratic oath, I think they forgot about that. They're there to generate an RVU and get a check as quickly as I can, in and out. So we need to make sure that as a patient, we own the disease, we understand it a little bit, and we have expectations, and we're going to hold the healthcare systems and those providers accountability. And along with that, it was brought up, I think, last night at dinner, this element of trust or mistrust, right? Because we can't engage our patients or the lay personnel to do these things if they don't trust the system. So we have to, again, on the side of what we can do, we have to be able to have trusted healthcare advisors that are lay people. I think at my table last night at dinner, it starts at, and Marlon touched on this actually, at the dinner table in the family. Who in the family is going to be the trusted healthcare advisor for the family?
Yes.
Making them understand, make them comfortable with these conversations, and knowing where you can go out and get access to various types of resources. Okay? I'm gonna get off my soapbox.
Dr. Jones, that was wonderful. And I completely agree with what Dr. Jones said. And I'll just say that in addition, it's particularly important when we have healthcare providers out there in the community that we see people trust, right? So if you have a friend, a brother, a sister, a cousin, whatever, somebody that you know in the community that says, I absolutely love this healthcare provider, physician, APP, that this person is so good, they truly care, genuinely care, then I think it's important as a reference to see if you can get in to see that person in clinic. And I have to say this, they don't all have to be black or brown. I have seen a good number of people, providers out there that are black, not black or brown, that also advocate for the underserved and are particularly interested. They're just interested in healthcare, doing their very best with healthcare. So ask questions of your relatives, ask questions of your friends, see who they're seeing, see how much they trust them. And I think it's one way to also advocate and be able to see these people to help improve our health.
Oh, that's helpful, thank you. Shifting focus a little bit, Dr. Everett, everyone here are not only Pan-Hel leaders, but they're leaders in their communities. And the purpose of this conversation is to have them take back, what we've heard here today to their chapters, to their families, their friends, their communities. What tips would you give them? He didn't mention he was a Kappa, so the red tie he thought was going to do it, but what tips would you give, to your bros, or my stores about what we can do to take back to the chapter?
Yeah, so I think, I've done many talks with different chapters around the city, and I'm sure every organization has their own health months and health programs. So I think those are important. But I also think that it's important I really want to focus and hone in on the importance of being able to have the dialogue about your health. That it is not taboo. I mean, I've had friends of mine who have had stents and did not even tell me, which I was really offended by. Yeah, I couldn't believe it that, I hanging out with the person, oh yeah, I have one of those. And, and so I think it's really important to continue to ensure that we keep health at the forefront. One thing that, if anything came out of COVID that was good, and so many things were bad, but one thing, it did show us that things can change overnight, right? And so what I always say it brought healthcare out to the forefront. Now we became, before it was just one of those things that healthcare, everyone went on about their daily life and did things, and it's just one of those things part of life. Now it is a main focus of just about everybody in this room, as we see people still, with masks and COVID's around. It's just a big deal. It changed our lives. So that being said, I think it's important to keep if in your programs for your chapters, I think it's important. Healthcare should be up there with, I know you guys probably do maybe some different financial services and different topics like that. Healthcare has to be there. That's number one. Number two is that, I'm going to do it again, I'm going to hone again, it needs to be talked about, and it needs to be not taboo. So if you have, there's nothing wrong with saying, oh yeah, I have prostate cancer and I'm getting it treated. There's nothing wrong with that. Once we get to that level, I think it'll be much more, we'll see much more advances in our healthcare. So if there's one thing, so to answer your question, the long-winded way is say, continue with the health advocacy, continue with the programs, and continue to be active from a health standpoint.
Adding to that, I think it's important as we start to focus on our pillars and what we're doing in our communities, not the big five, right? Not, teach people about cancer, teach people about, breast health, teach people about prostate cancer, and others. Dig deeper. There are so many illnesses that affect our community in a negative way that people die from that they just aren't educated about. It took Black Panther to die to get the guidance changed on colonoscopies. So these are things that we need to talk about, to Dr. Everett's point, and I think that, taking those steps back to your chapters, talking to physicians in various specialties that you're unfamiliar with, to have them come in and speak, to talk about, symptoms and what else you're, what you should be looking for and other things is very important, I think.
Models. Overall, I'm a great advocate for cardiovascular health in everyone, particularly the underserved. And I sit on the board for the American Heart Association within the Chicago area. And one of the things that American Heart Association has done very well is figuring out ways to educate the younger generation. And I think that's a very, very important model to follow, because if we think about it, I have a patient, not even one patient, a whole bunch of patients in my clinic that don't believe they have high blood pressure because they don't feel anything. Who does that, right? Think about that. We talk about high blood pressure or hypertension as the silent killer. How can you tell me you don't feel anything? If you don't feel anything, and so you don't think it's necessary to take your blood pressure medication, right? So I think that education is huge, and American Heart Association has done, that's one of their missions, is to educate, right? Reducing the amount of sugar-sweetened beverages in schools, banning tobacco smoking in public places and so on. Things like that are all things that have made a difference in our communities. And so for me, the focus for all of you in your chapters to take back is education, especially educating the younger generation. I think that's particularly important. If we can educate the younger generation, then they grow up and they think differently, right? Dr. Everett was talking about how important it is for us to share information amongst ourselves. Well, if we teach the younger generation to be open about their health, then they grow up with it. It becomes part of them. It becomes a habit for them. If we encourage our younger ones, more of them, to go into healthcare related fields, then we see more people like us up there when we are ready to go see a physician, or people like us making decisions up there in terms of healthcare that affect us, that affect our communities. People like us creating guidelines for healthcare that will then help improve the health of the underserved. So I think focusing on the younger generation is important. Getting education material across the schools. In my daughter's school, they teach them, and this is also part of what the American Heart Association has done, they teach them how to perform CPR, right? That's particularly important because, again, these are leaders of tomorrow. So we need to focus on bringing them up, educating them, mentoring them to take on those positions that we think will influence our communities in the future.
Just real quickly, I just want to obviously echo the comments previously made by my two colleagues here, particularly in terms of getting involved with all of the resources that the American Heart Association has available to the community. There's one other thing I want to comment that may prove to be very valuable as well in this particular space. A lot of insurance companies and even some of the healthcare systems are rapidly developing these clinical care coordination programs that are specifically designed to address population health in some of these chronic disease states. Most of those staffing models ideally should have a community health worker as part of that clinical care coordination team. That community health worker is your next door neighbor, or someone around the corner, someone that is a lay person that's embedded in your community, that's connecting with you directly and helping be that trusted healthcare advisor for you, that's going to be able to connect you through all the other available systems and get fully integrated into hospital systems or ambulatory systems or other healthcare systems, such that you have this nice continuum. So ask your insurance. I think we had somebody from Blue Cross here. I met last night, but I don't know if he's here yet. But anyway, ask your insurer. Is there a clinical care coordination team and or a healthcare provider assigned to our area and or district? Get connected with them. Take advantage of that resource. And that's something I think needs to continue to grow and further develop, and I think there's a lot of energy around growing those types of programs to help patients and lay people to become more informed, more involved, and improve trust.
Thank you. So we've covered a lot here, but I wanted to make sure we had some time for Q&A.
Heart disease is the #1 killer for Black females. What kind of symptoms should we be looking for? Because I know that it's sometimes labeled as the silent killer, and I've had some friends that have passed away in their sleep. We don't, and the person was healthy. We talked to them like maybe the day before, and then all of a sudden they're gone. So just trying to get more information on like heart disease. What symptoms should we be looking for as Black women and Black men?
Yeah, I can take that. So that's a great question because, you know, we've done a great job with teaching men about the symptoms of heart disease and what they should look for. And now we see that there's a decline in men having heart attacks and dying of heart attacks. But over the last 20, 30 years, you see women's incidence and the prevalence of heart disease and that going up. And that's because I think a lot of it has to do with women have symptoms that are what we call atypical. You remember, I know you heard that term now with COVID, but basically atypical, meaning that it's not the typical chest pressure and when you're sitting there and start to sweat. It could be back pain, it could be GERD-like pain, or acid reflux pain. I'll give you one quick scenario. There's a guy, so I used to live in my neighborhood, and it's an old, cantankerous guy. He lived in my neighborhood, lived right down the street. Everybody hated him, but he loved me because I was a doctor on the block. So one night he comes to my house, and called him Old Man Eddie. He came to my house, and he knocked on my door, and it's about 10:30 at night, and he had a box of Prilosec, and it was empty. And he was saying to me, "Doc, I keep having this acid reflux, and I'm taking 30 pills of the Prilosec, and it's not going away." So, and I'm like, "Dude, what are you doing? We got to get you to the hospital." So, sure enough, after convincing him and all that stuff, I actually drove him to the hospital. He was having a heart attack at that time, and we took him. Yeah. So, those are some of the atypical symptoms. But in terms of just get back to women, women. One of the problems, and someone mentioned this last night, which is true. Women, unfortunately, take care of everyone else but themselves. Take care of the kids and the husband and everyone else, and don't take care of yourself. So first of all, know your body. If something's wrong, don't be afraid to talk to the doctor about it. But it's often atypical signs with women in general. It's back pain. It's just sweating. It could be fatigue. Little simple things like that. You have to know your body. And that's one thing you should do. And most importantly, don't be afraid to give that doctor a call and say, something's just not right, and get into the doctor's seat.
Okay, next question.
Hi. Is there a resource, an app, or website to find African American doctors in your neighborhood? Not everybody lives on the South Side. Some of us are in western suburbs, other areas. So how do we find African American doctors?
I don't know. Go ahead.
Marlon, I'm gonna let you go then. I'll come after you.
Yeah, it's all right.
All right.
Yeah, I mean, in terms of resources, first of all, a lot of it's word of mouth, for sure. Secondly, we've got Google. You can just ask. There's no real resources I know. Paul, do you know of any? Okay.
Yeah. First of all, big problem. I think, I believe it was Channel 2 News did a nationwide, story on this a few months ago. Probably more like actually it's back in February. And they came to interview myself and one of the few, probably the only other black physician in the hospital in the CV space, was a resident on rotation in cardiology. And they highlighted the huge deficits in terms of access to and number of African American cardiovascular providers in the country. I mean, we can look at Chicago alone. And this is a big topic. And I'm not gonna, again, spend an hour on this, but you easily can. Because this is another one of my areas of passion in my leadership roles over the past 25 years, and for 22 of those years, I developed and had our own physician group practice to specifically meet some of the needs that we're talking about here. And Marlon, you gotta help me out, Toshi, but I think Dr. Everett presently is the only African American cardiologist practicing in the community on the south side right now.
In cardiovascular?
Yeah, in cardiovascular, which is a shame, and which is why I challenge myself personally, although I would love to retire and, you know, do all this other kind of stuff. I said, morally and ethically, I don't have a right to do that at this stage of the game. So I'm challenged with that. But in my roles, when I try and recruit African American physicians, and there are a lot of talented African American docs that are being trained and are out there in the country that are recruitable. But there's challenges in terms of getting them inside the system and keeping them in the system, and I'll leave it at that. And I fought the battles. Okay? So there's work that needs to be done there. So there's a huge deficit, first and foremost.
Yes.
Now, in terms of what resources are available now to try and find it, there is some software out there. Black Telehealth might be one. There's a group of guys, I'll have to get this information to you, circulate it, but he developed a app and a network of trying to connect all of the African American physicians throughout the country within this software and network that one could tap into. I think it's Black Telehealth. And there's another organization that's presently working on an app. They have the software platform already that's trying to develop this network of African American physicians because it's hugely needed. Not to mention the fact that literature supports it. When patients go, African American patients go and see African American physicians, the clinical outcomes are better. That's published as literature. One of obvious reasons is trust, right? You're gonna engage better, et cetera, et cetera. So, I'll give you that exact, we should give that information to them before we leave.
Okay.
Yeah, and we can charge Black Health Matters to help us out here.
Yes, we will.
You know, maybe Black Health, that could be one of the initiatives for Black Health Matters. blackdoctor.org is another website. Yeah. Can I forget? Remember, the Association of Black Cardiologists, the ABC definitely has a resource. abcardio.org is AB Cardio, Association of Black Cardiologists.
One more question.
Yes, another question.
Two more, if you don't mind. We got time for that?
Yes.
Okay, so I have a sort of a two-part question, Doctor. Thank you for presenting. The first question is, you talked about mistrusting the healthcare system. And we all, no, I know. So as you guys alluded to earlier, and thank you for being here, you talked about mistrusting the healthcare system, and part of that, as we know, is the Tuskegee experiment. So, and part of the issue, I guess, today is the development of the vaccines for the pandemic, for the COVID virus, where people didn't trust. Now, I was one of those folks initially, but doctors did a good job doing Zoom calls to sort of explain the rush to get this and how all the steps it took to get a vaccine normally took 5 years, but they skipped a lot of those steps based on money, based on volunteers, all those different things. So how do we ensure that that continues? Because I guess that was a pandemic response. How do we ensure that that continues to ensure that we continue to build that trust, especially with people who look like us in the healthcare system, number one. And number two, is there some type of committee or doctors who would be willing to come to, not for things like this is huge, so you guys come here, but like to various chapters, for their little small health fairs to do things. And I know that your time is precious, but if we could get folks to be more personal, I think that would go a long way as well versus, just coming to big things where we only have maybe a small percentage of our members here, whereas you guys can touch millions of folks if we just had some type of volunteer committee who would go out to school. There you go. That's my question or statement, whatever you want to take it.
I think that in terms of your first question about the pandemic and developing trust in the system, I think it's, one of the ladies that I was sitting at a table with yesterday said trust is earned, and that's absolutely true. Trust is earned. And I think that the healthcare system understands that part of the reason why we have very little enrollment of African Americans and Blacks and a lot of underserved folks in research trials is particularly because of that trust issue. So I think that one of the ways that we can improve trust is just the way that we did it with the pandemic, which is involving the healthcare workers or the healthcare system overall in encouraging patients to be part of this, right? Giving information, educating patients on how things were developed, how the process of how whatever it is that we're talking about that people can trust is how that has passed through the process. And then I think the other thing is also if you have a healthcare provider that you trust, you can ask them. Just ask the healthcare provider, hey, I trust you, and a lot of my patients do this. I trust you, what do you think about this, or what do you think about that? And if your healthcare provider says, yes, I trust this, and they're able to explain to you the process, then just like the pandemic, it's easier to get yourself enrolled or to do whatever it is that they're asking you to do. So that's number one. And then in terms of the other things, in terms of panels and speakers and things like that, I think we're all here. Many of us always, because there are not very many of us, like for me at Rush, I'm the only Black female cardiologist, in fact, I'm the only Black cardiologist now at Rush, Dr. Kim Williams left. So I'm the only Black cardiologist at Rush, and of course, the only Black female. So I think that we're all here, and we're all very willing because we want to see the community better, we want to see things improved in the community. So if you have any questions or if you feel like we could be a good resource to you in any way, feel free to reach out to any of us, and we're happy to help.
We have time for one more question, depending on how long it is. 2 more questions? Okay.
Okay, I will try and keep mine short. Good afternoon, and again, thank each of you for going the extra mile. But my question kind of centers around the COVID and how the heart is being impacted or affected by COVID. And there are a lot of people who have taken advantage of the vaccination, and as a result, when they end up getting COVID, now they're starting to have issues with their heart, as well as some folks have ended up having strokes. So the question I guess I have, in addition to all of the assessment that we are generally receiving every year through our annual exam, what other type of tests need to be performed during that exam other than the stress test and that other special test that I can't think offhand, other than EKG, that special test that cardiologists or heart specialists should be implementing now as a result of COVID?
Yeah, I'll just start, and then my colleagues, I'll be quick because I realize we're limited on time. Overall, EKG, echocardiogram, cardiac MRI is the other one, right? So when we're concerned about, let's say, inflammation or myocarditis that comes from COVID or the COVID vaccine, which by the way are pretty rare, then a cardiac MRI is one of the ways that we can kind of help ourselves sort through that.
Yeah, I think just in general though, and I get this question a lot, Doc, just check me out type question. And so I think one thing, just about every hospital many hospitals have this $49 deal where you can get a CAT scan of your heart. Now that CAT scan is looking for calcium, okay? It's called a heart calcium score. Now, if you have no calcium, that's a good prognosis. Okay, if you have some calcium, it could mean that there's plaque buildup. By definition, there is plaque buildup. We don't know if it's actually obstructing blood flow or causing problems, but there is plaque. And calcium is a surrogate marker for that. So I think that one thing you can do in general that I forgot to mention earlier is I would take advantage of everyone if you are not, if you don't have if you're not, don't have any symptoms or anything like that, I would just, and I've had all my family members do it as well, is to get that $49 heart calcium test. You can call it up, it does not need a prescription.
I'm gonna comment, just try and keep it brief. I think it's an excellent question, first and foremost. I've been involved in cardiovascular screening for many years. The bottom line is, unfortunately, in the cardiovascular space, we have a lot of objective science and literature to help guide us in this particular space. And there's a lot of stuff out there. The bottom line is, it starts with the basic history and physical examination. And with that history and physical examination, you're going to be able to come up with a particular risk profile for that individual patient. On one end of the spectrum, based on history and physical, totally normal, no biggie. There's a continuum of this. I examine that patient, I find something on exam, or if there's something in your history, family history, that would predispose you to development of a particular disease state, then that's going to dictate what type of battery of screening tests that are provided. And I'll just use one example, right? Abdominal aortic aneurysms. I'm going to speak on the vascular side of this. There's well-defined screening parameters and guidelines for abdominal aortic aneurysm disease. Recently, talking to one of my colleagues, there's some data published out of the Mayo Clinic and other sites that was published in the surgical literature. Of those patients that present to the emergency department with a ruptured aneurysm, okay, which carries 80% mortality if not treated sooner than later in the hospital, but of those patients who had been seen by a provider within that prior year had not had an abdominal clearance documented, had not been, despite known risk factors, was not referred for screening of an ultrasound of the aorta. So it starts with, again, physical examination and history, and based upon that, that's why, again, as the patient, as the consumer, holding your provider accountable for doing what they need to do. Examine me. If I don't have a pulse, I may not be symptomatic, I'm a diabetic, but you've examined me, so you've detected I don't have a pulse. That's going to dictate a whole other level of screening and level of aggressiveness in terms of evaluation. And we know that if you have peripheral vascular disease, guess what? You have increased risk for carotid disease, you have significant carotid disease, increased risk for stroke, cardiovascular disease. So that's going to, spiral the whole thing, but let's not forget the basics, which is examining that patient and doing a good history.
Okay, we have time for one more question.
Okay, I'll be quick. So I'm 31 years old. I've had hypertension since the 10th grade, mainly genetics, and I'm from Houston, so I like Cajun seasoning and butter and salt in my food. But my daughter is 9, and I don't want her to grow up with like the same things that I've grown up with, so you kind of briefly talked about it. What are some other resources I could work with my daughter so she doesn't grow up and have to be on high blood pressure medicine like I am right now?
I think actually the American Heart Association has a great website. It's called heart.org, where you can go to get a lot of information about different cardiovascular disease states. and how to manage them. They even have things like cooking, they give you information on things like, diet and exercise and monitoring your cholesterol and stuff like that. They even have recipes for cooking and things like that. And your daily recommendation for salt intake, which as you know, increases the risk of hypertension or blood pressures that are just very high. So I think starting from there is a great way to do it. And then I think when you go to your parent-teacher conference, school meetings like at the beginning of the school year or something like that, it's important to bring issues like these up with the school district as well, to say, can we have education for these kids on these particular topics? Because they're health topics and they're very, very relevant. Amongst African Americans, hypertension is the number one cause of death because it leads to heart failure, end-stage renal disease, dialysis, strokes, all of those things that we know of that increase the mortality amongst African Americans. So it's not something to be taken very lightly at all.
Thank you. If everyone can do the post-session survey on your phone, I'll just give it one more minute. We're going to start wrapping up.
Good afternoon. So we're just here. There was a question from our organizations. My name is Dr. Aronica Williams. I wanted to let everyone here know, I'm a family physician. I'm the medical lead of Sigma Gamma Rho Sorority Incorporated. There was a question about what resources our organizations have available. We have a task force, a medical task force. All of you all have a representative on that task force, and so you're looking at 2 of your national representatives, and so anything that you need for your chapters regarding programming, regarding tools and tips, we have a full task force that we are at your disposal, and we can do whatever you need us to do to help empower your chapters to be healthier, be successful as you have those conversations. And so this is the lead of that task force, and I'll turn that over to her as you do your survey, but I wanted to let you know we are here and we are available to help you.
And thank you, and I'm with Zeta Phi Beta Sorority. And again, we've been working together behind the scenes since May 2020. Started out as COVID, and now we're health and wellness. And we are here and available to help you with all sorts of resources. And if you go back a few months or maybe years on the NPHC website, you'll see some of the presentations that we've provided and resources around COVID, and look forward to more resources regarding these topics and others. Thank you.
Thank you. Next slides. Okay, these are our takeaways today. We are very short on time, but thank you all very much for coming. I want to extend my heartfelt gratitude, see what I did there, to all of our panelists, to all of you all for staying and attending and engaging with them. Thank you so much. I know that Black Health Matters is going to have resources available with contact information for all of you all as well. So please stay in touch with these amazing physicians here, and please make sure your chapters know what we talked about today. Thank you.
Again, I promise to give you that follow-up on the physician network, Black Physician Network, and Dr. Marlon Everett was correct. It's blackdoctors.org. You can just go and Google blackdoctors.org. Blackdoctors.org. Again, the ownership of that is local, and they should be able to provide a network of Black physicians.
What an incredible program, right?
Yes.
Extremely important and valuable information. So thanks to all who attended, and thanks to all who have participated. I just want to say that Black Health Matters, once again, is involved with a variety of different health states, and we can certainly talk to you about any sort of programming going future. But I want to also just pass along to Donna Jones-Anderson, Madam President, for the final words regarding this important segment. Thank you so much.
Very good information. Thank you, doctors. Thank you so much. They're so special because they take care of us, right? And because they give us the information that we need. I know my mom had some heart pain and she had to have a stent. And she was asking everybody, should I get it done? You know, because they said it lasts 15 years or something like that. And yeah, it's a no-brainer. Yeah, you need to get it done. So that was like 10 years ago. My mother-in-law had it done, I guess, about 20 years ago. Still there. She's 94. So if you need to have something done, listen to the doctors. Okay, thank you so much, Boston Scientific. Thank you so much, Black Health Matters, for all the information. We love all the information that you dropped on us today. Thank you. And now we will transition to our next presentation, and we'll just give a few minutes for the transition.